Thank you for taking the time to watch this short video. Dr. Brian Schwartz and I will provide you with some information regarding upcoming changes to tiered response protocols in Toronto. As it is too large to place on MobiCAD, the full video will be available on your station computers. As part of Toronto EMS's continuous fine-tuning of emergency medical response to the public, we are adjusting our tiered response protocols in May of this year. The changes are being made as a result of the recommendations of an expert panel of physicians, including Dr. Schwartz, who you will hear from in a moment, and have been presented to the Tiered Response Committee, myself, the fire chief, the deputy city managers, and the city manager. As you know, Toronto EMS continuously makes changes to practice based on supportive scientific evidence. These adjustments are patient-focused, medically based, and supported by a study of over 116,000 Toronto EMS calls made possible through your support and the data collected by Toronto EMS paramedics through the use of electronic patient records. You will notice changes to when Toronto Fire Service is or is not automatically sent to a medical call. It is important to note that this change will not impact calls such as vehicle extrications, hazardous materials, technical rescue, etc. Let's take a moment to hear from our Tiered Response Committee co-chair and Toronto EMS medical advisor, Dr. Brian Schwartz.
We've been working for many years on the medical basis for tiered response and being sure that, to the best of our knowledge, firefighters are going to the calls that they're most needed on. Now, primarily because of electronic patient care records, the EPCR, we've got improved data collection. And it's not subjective. We can capture on an ongoing basis the calls for which interventions that would suggest the opportunity for firefighters' first response in a complete fashion, in a comprehensive fashion, so that we can analyze them and look back on the MPDS determinants that these interventions were used on. So we're able to use improved technology, improved data collection to improve our recommendations. So these recommendations were made by the 5 physicians who are involved with EMS and fire in the city, myself, Dr. Michael Feldman, Dr. Rick Verbeek, Dr. Noah Foreman, and Dr. Martin Friedberg, all reached consensus on these recommendations. These were based, as I said, solely on the evidence that we had from the EPCR data. I'm just going to walk through our methodology for you. We reviewed a 6-month sample of calls, and that consisted of over 116,000 calls in the EMS database, which resulted in about 78,000 patient transports. As you know, there are over 1,200 medical priority dispatch system determinants, but 95% of the calls that we go to are in just over 200 of those determinants. The outcomes that we used, rather than using C-tests now, the outcomes that we used were the calls in the data set that required a pre-hospital intervention which suggested the opportunity for a firefighter first response. And again, this is not a subjective outcome anymore like C-TEST is. It is an objective outcome as to what interventions were provided, either by EMS or fire, that would have driven a firefighter first responder. Our determinations and our recommendations don't include any calls that firefighters are required for non-medical reasons. So as prime agency, fire services continue to respond, or this is out of the realm of our discussion, to hazardous materials, fire suppression, technical rescue, or forcible entry. But our recommendations do include firefighters going on calls that they heretofore didn't go to and will be not required on some of the calls that I've described. It's very important for our dispatchers to understand that upon arrival of the paramedics, or if the patient's conditions change, that fire can still be assigned to calls that aren't necessarily on the list because of particular circumstances that the caller indicates or that the paramedics have assessed. So the key things to remember are, first, these are scientific recommendations based on evidence as determined by the physicians. Secondly, that this is a continuous process that will continue to reevaluate those scientific recommendations in order to continually improve the accuracy of sending firefighters as first responders to calls. Number three, that these are medically based firefighter interventions and don't include all the non-medical interventions that firefighters provide in conjunction with EMS. And it doesn't change the need for rapid EMS assessment and treatment based on the situation, independent of whether or not firefighter first response skills are required. So I thank you for your attention. I trust that our recommendations will be carefully considered operationally and logistically, and that we'll be able to meet in future and discuss how we continue to improve our tiered response system.